So not only would I consider starting a bariatric program for adolescents, I'd do it over and over and over again. And I've just done it in Denver. Thanks for the opportunity to come, Janie and Mac, to present some data. I guess I'm the data guy then from the standpoint of this session. And I wanted to just recognize quickly, because he didn't, I think, in his in his modesty, talk about guidelines that are coming along. Mary gave us a really nice timeline that talks about the, over time, the guidelines and how things have changed. But I think the AAP is now really almost prepared to make an endorsement of this, and so we'll be looking very carefully for that in the coming weeks. This first slide really is just to make the point that we're talking about severe obesity, morbid obesity, whatever term you like to use, and we're talking about taking surgical action against it in teenagers. But this actually points to the real reason. This is an Israeli study that looked at individuals, teenagers in particular, that had various weight levels in their teenage years, and then did a 40-year follow-up. And what this shows you in a snapshot really is that cardiovascular risk rises dramatically for those who were only obese as teenagers. So a 5-fold increase in cardiovascular mortality within a relatively short period of time if you were only obese as a teenager. So we're talking about individuals now that are in a severe obese category, and although these data don't speak to that, I would certainly believe that the risk of early mortality is at least twice what you see on the slide here. And so it really does, again, give you that confidence that we're not talking about something that is a minor problem. We're talking about a problem that is severe obesity in teenagers that will be life-limiting. And I think that most of this audience, a surgical audience, certainly knows that surgery is not just an anatomic procedure. Surgeons are engaging physiology that is latent in these individuals, that can be used to the advantage of the teenagers to maintain weight loss in a way that dieting really doesn't. Dieting certainly does invoke a response, a very physiologic response, an adaptive response that seeks to regain the weight. Surgery gets in the way of that physiologic adaptation to weight loss, and it allows us as surgeons to tell a family that we can do something for you for now, for 6 months, 12 months, and as I'll show you in the later slides, hopefully for many decades to come. So you heard mention of the Teen Lab study, and we're grateful. I'm grateful to my collaborators, several of whom are in the room, from Texas Children's, Mary Brandt and Matt Carmen from Birmingham, but also Mark Mikowski and others, to really come together a number of years ago, 2006 or so is when we were first funded, to really gather long-term data on a large number of patients, about 242 actually consecutive from 2007 to 12. And also grateful to our partners in research at the NIH who really have seen fit to continue the funding until now, to 2021. The age at surgery for this Teen Labs cohort was about 16 and a half. You see here the histogram of that, the age at surgery, but anywhere from 13 to 19. This is the current age for Teen Labs participants. You see the histogram moving over to the right. We have some one at least 29-year-old now in the study that is continuing to be followed. So I'm hoping that this study will continue to produce very good long-term data. You have already seen this slide, which is one way to represent one of the big impacts of bariatric surgery, and that is weight change from baseline. We see about a 30 to 33% initial weight loss, And then whether it be a teenage study or whether it's an adult population that we're studying, we see this inexorable leveling out, regain of some weight over time. And I think that we are really eager to share with the public, the longer term outcomes of this study too, which we're very proud of. The thing that, of course, that when you look at these averages, you have to realize that there's a lot of data buried in these really nice stylized curves that look like everything is very tight and narrow, but there is a lot of variability in this data. And I really think that the future will be understanding that variability and understanding which operations are best for which populations and how to predict which operations will be best for individual patients. The next slide talks about comorbidities. We certainly realize that weight is a big problem, but it's really the comorbidities that are, I think, the more life-threatening problems associated with weight. It's very gratifying to see that the remission of type 2 diabetes happens between 90 and 95% of the time in the teenagers that we're operating on. This kind of data, to me, validates our original hypothesis in teen labs. One of the underlying hypotheses, the main hypothesis in teen labs, is that operating earlier for severe obesity, earlier in life, will be better than operating later in life. And those of you, I think a lot of you are adult surgeons, understand that your adult with type 2 diabetes has more like a 60% chance of a remission, of a full remission of their diabetes. So I think that, again, there is an age difference and a plasticity in metabolism, perhaps a difference that has to do with just the duration of the insult to the islet cells, the stress, the fatigue that goes along with these longer-term disease in adults. Prediabetes, dyslipidemia, elevated blood pressure, and even abnormal kidney function, the things that we don't usually even think about, we can measure and show significant improvement of abnormalities in these organ systems after bariatric surgery. Really do want to highlight something that was mentioned earlier on, and that is nutritional effects. Now, I'm just highlighting here basically three areas. Ferritin and transferrin are both kind of linked to talk about the risk of iron deficiency. And we certainly see increasing evidence of iron deficiency in both of these operations. And so it really does bear on that preoperative preparation, as well as the active monitoring of these patients postoperatively and the anticipatory guidance that we need to be providing for them as they age and as they begin to take life as it comes and become really more normal in their thinking about their lives. They have to understand that they are at risk for nutritional deficiencies. Teen Labs is collecting a lot more nutritional data than you see here, and I think, again, we'll be able to highlight some of that in future publications. B12 and even vitamin A, something you don't see very often in the bariatric literature, may be a risk in at least gastric bypass patients. So now I'm starting to ask them, do you have any issues around night blindness or, difficulties in low light? And I think that we have to really pay attention to the, perhaps effects of these operations that are not so obvious. So this is my brag slide, and I'm bragging in part on Mary Brandt in largest part because her program is the program in Teen Labs, I'll say, unblinded, that has the very best follow-up. But I think as a whole, we're doing a very good job of keeping track of these patients, keeping them in the fold, and keeping them true to their original promise, which is to help us tell the public about the long-term effects of bariatric surgery in teenagers. So at 5 years, 89% visit completion rates, up to the 90s at years beyond 5, is really a true testimony to how hard the coordinators are working, and I think we all take this very seriously. PCORI also recently completed a bariatric study, and in the interest of time, I'll move forward through the methods and just say that the study was looking to see what are the long-term effects using big data data from really the EMR system in a number of healthcare systems. And the results show here, and they're just actually going to be released soon in SWORD, they're in press, that the sleeve gastrectomy really does dominate now in adolescents to the detriment of the use of gastric bypass and certainly gastric banding. Really, there were very few in the later data sets in 2014. The weight loss kind of tells the story about why the band is dying. It's a rapid death, and you see here, only about 10 or 12% weight loss with the band, and much more, as expected, greater weight loss with both sleeve gastrectomy and gastric bypass. These could not be discriminated between. In other words, they were statistically similar, the sleeve and the bypass, even though it looks like there is a divergence there. For those who like categorical data, more than 20% weight loss from baseline at the 1 and 3 year time points is shown here for gastric bypass and sleeve gastrectomy, and more than 85 to 90% of them maintained that marker of success. When you look at greater than 30% BMI loss from baseline, again, sleeve gastrectomy and gastric bypass are similar in their performance, and the band is poor. Longer-term data, you heard FABS-5 mentioned. We looked at 58 teenagers on average 8 years after surgery. So their baseline BMI had been 57. And we compared them to a group of treatment-seeking teenagers who had also severe obesity with a mean BMI of 51, baseline age of 15, and we're able to look at them again 7 years following surgery, and wanted to look at the durability of weight loss, surgical weight loss. And as you see here, the competing risk of not undergoing surgery if you are a severely obese teen is not well known, but most of us can imagine they're going to gain more weight on average, and that's what the study found, a 6% weight gain for those teenagers who were in the non-operative treatment group who were looked at again at 7 years. The surgical group, and these were all gastric bypasses, lost the typical amount of bypass weight at 1 year, 37%, and then maintained the vast majority of that weight loss at 8 years, as shown there. What happened to the diabetes? At baseline, those in the surgical group in red had remission of their diabetes, again at expected rates of remission, and those in the non-operative group with diabetes at baseline maintained their diabetes, and then others who didn't have diabetes at baseline actually developed it. That's the incident, 14% incidence over that period of time. So other things in addition to diabetes that we looked at, dyslipidemia and hypertension, remission rates of 64% and 76%, as you see here. And AMOS was mentioned, which is a study run by investigators in Gothenburg, Sweden. And what you see here is Torsten Olbers is the PI of the study. He again duplicates what we saw in FABS-5 with a prospective study showing at 5 years weight gain in the group that did not undergo surgery, weight loss about a third as typical in bypass in the teenagers that underwent surgery, and an adult control group, indistinguishable weight loss. So it's kind of interesting. The weight loss is the same, but the comorbidity outcome in certain types of comorbidities is better in the teenagers than we see in adults. Quality of life improves. As you see here at baseline, we measured weight-related quality of life in teen labs. And as some of you may know, that when we measure these with similar instruments, patients with cancer and patients with severe obesity, we find that the patients with severe obesity have more compromised quality of life than those with cancer. And that improves essentially up almost to community norms for lean individuals at 3 years. And that happens over the course, a gradual course, as you see in the curvilinear plot on the right. We can't talk about the benefits without talking about some complications. Long-term complications seem to be few. We see the bulk of the complications within the 30 days, and as we published in 2016, that the complications over 3 years tended to be most commonly, and these are, you can call them complications, but they're events, healthcare utilization events, upper endoscopies, cholecystectomy, stricture dilatation, and then lysis of adhesions for bowel obstruction, and a few internal hernias as well. So I'll end by simply highlighting a human aspect of this that Gina Collada captured in a number of interviews and published in a high-profile article in the New York Times not too long ago. And I'll highlight, though, a medical doctor's take on the situation when he was asked by Gina, what do you think about adolescent bariatric surgery? And those of you who know Lee Kaplan know he's one of the greatest thinkers in bariatric medicine. And he was less concerned about the possible nutritional complications and osteoporosis in these teenagers later on, and more really concerned in his mind that their lives will be destroyed if they don't get some serious weight loss. And by destroyed, he means medically, socially, and economically. And so I do take this to heart. I certainly believe what he says is true. And it helps keep me excited about this field. It helps me stay interested in data collection. As Mary pointed out, I think we have an obligation for long-term data collection. So I appreciate your time.